Pakistan, from Indonesia, of course, from Malaysia, from Korea, South Korea, and Japan, and Thailand, and also Malaysia and Brunei, isn't it? So I think it is a good opportunity for us to hear from you all about the regulation of the medical resident stipend. I think I've met Dr. Okamoto in Rwanda, I think last year with Dr. Adib also. We discussed about the problem in Indonesia. So at that time I talked to Dr. Okamoto, can I what invite you as a speaker for in Indonesian Medical Association seminar about the Junior Doctors Network, and she said, okay. So I think this is the first time that we invite all of you in one discussion. But I would like to highlight some 3 points that we need to hear from you and discuss and what want to have some opinions from you is that Indonesia, I think it is the only nation in the world that medical residents or trainee is not having their rights to have the medical stipends or salary or whatever the name, but that's the problem in Indonesia. I don't know in other country, but I think when I was a PhD in Japan, I think the resident got some salary, and also in Singapore when I finished my training there in NUS, I think I got 2,600 Singaporean dollars. So I think that's amount is sufficient for the residents to live, I think. In Indonesia, the age of the medical residents is between 25 until 55 years old. It is an adult age, and also some of our residents already have the family that they need to keep some money that. So the problem is, I don't know what is the problem in our government. So I think we need to hear from you about that. And then second one is about the working hours. Indonesia up till now do not have any regulation on working hours. So I think it is a good opportunity to hear from all of you. And the third one, I think we have some problem relation with the government. So I think the one that happened in Korea, such as the resignation from junior doctors in South Korea, is a memorable thing, I think, for us to hear from Korea also what is their experience about it. So I think for this occasion, I would like to say thanks to all of you to attend this meeting, and also to the Dr. Dinda and team, Dr. Ratu, and also the external team of the Junior Doctors Network Ikatan Dokter Indonesia, Indonesian Medical Association. So I would like to say thanks also to Dr. Adib to attend this meeting, and also all of the official of Indonesian Medical Association, and also Junior Doctors Network Indonesian Medical Association who attends this meeting. Thanks to Dr. Ratu, and back to you.
Thank you, Dr. Tommy, for the speech. And now we'll have Dr. Muhammad Adib Humaydi, PhD Orthopedic Surgeon, as the President of Indonesian Medical Association. Dr. Adib.
Thank you, Dr. Ratu. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone here, especially to the Junior Doctor Network ED, Indonesian Medical Association Chairman and the team, Dr. Tommy and the team, and also from Pakistan, Malaysia, Thailand, Korea, South Korea, and Japan, Brunei. Thank you coming and participate in this evening, discuss about the medical doctor stipends. And we stand here today united as the medical doctor resident, which are the backbone of the medical field, especially in hospital. More than a decade ago, maybe me and Dr. Tommy and others also was a doctor resident, because I'm the orthopedic surgeon, Dr. Tommy the cardiothoracic surgeon, which here I also speak based on our experience. We dedicate ourselves to years of vigorous training, the serving people and the community with patient and care. However, a crucial aspect of our journey is often overlooked: the fair compensation or stipends and manageable work hours. Many of us face inadequate stipends that struggle to cover basic living expenses. This financial strain creates immense pressure, diverting our focus from patient care to financial worries. Furthermore, the grueling work hours we endure can lead to fatigue, burnout, maybe also depression, and ultimately compromise patient safety. This is where the medical doctor organization, like the Indonesian Medical Association or Pengurus Besar Ikatan Dokter Indonesia and the Junior Doctor Network Ikatan Dokter Indonesia, Indonesian Medical Association, become vital, important. It's very important, yeah. And we need the collective voice to advocate for regulation that ensure that livable stipends, compensation that reflect the demanding nature of residency and allows us to focus on our training, reasonable about the work hours, limits on shift and call schedule to prevent exhaustion and promote well-being for both resident and the patient. Together, we all can push this issue to the forefront in the globally, in our country, to government that responsible for this and other side that responsible for this issue by put our voice in front and lobbying the government and the hospital. We can create lasting change. As the medical doctor, we deserve fair treatment, and our patient deserve the best possible care, which can only be delivered by well-rested and financially secure the resident. Let us join hands and fight for the future where our dedication is valued and our well-being is protected. Together, we can revolutionize movement, the medical residency experience for the benefit of all, ourselves, our patient, and the entire healthcare system. Thank you. Enjoy the discuss in this evening. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Adib. And now the discussion will be led by Dr. Maizan Khairunisa from Junior Doctors Indonesia Network. Dr. Maizan, you can lead the discussion.
Thank you, Dr. Ratu. Good evening, everyone. Thank you, Dr. Ratu, to introduce me as tonight's discussion moderator. First of all, I want to say greeting first for all the panelists or representation from South Korea, Dr. Song Eugene and Dr. Ko. Hello, Doc. How are you?
Yes, thank you for saying
Can
that.
you
Thank
hear?
you. How are you? Yes.
Yeah. Can you hear me clearly?
Yes, very well.
Yeah,
Yes.
okay. So I want to welcome to Dr. Maki Okamoto, cardiologist from Japan, Dr. Mer Muhammad Adel Riaz from Pakistan, and then Dr. Hakim from Brunei, Dr. Tay Min Lee from Singapore as a radiation oncology resident now, and of course Dr. Huzi Moon from JDN Malaysia, Dr. Kitty Chai Mongkoku and Sabditat Itisip from Thailand General Doctor Network, and of course my friends from Indonesia, Dr. Dinda and Dr. Tommy. So ladies and gentlemen, on the occasion of World Day for Safety and Health at Work, it is essential to highlight the significance of regulating medical residents' stipend and working hours. Medical residents play a critical roles in healthcare and often working long and demanding hours to care for patient, ensuring appropriate stipend, reasonable working hours, and fair salary compensation for those essential health workers is crucial to, of course, for their well-being and as well as to quality of care in the health system care. So tonight, we will begin our discussion. Before we have a good discussion tonight, maybe I will go to my friends, Dr. Dinda from Junior Doctors Network, to present data regarding tonight's topic. So without any further ado, we will hear first presentation from Junior Doctors Network Indonesia that will be presented by Dr. Dinda. Dr. Dinda, time is yours.
Thank you, Dr. Maizan. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. I am so grateful you guys can make time for this occasion, which takes, I hope, just 2 hours for the longest time. Hello, Dr. Song Eugene, Dr. Maki, Dr. Adil, Dr. Dong Kyun, and Dr. Hakim, Dr. Lee, Dr. Shi, and Dr. Zhao Yupei, and Dr. Kitty Chai from our Asian communities. Allow me to explain with slides. Oh, can you make me? Can you cancel the disabled? Buka de Dr. Maizan ininya. Apa?
Already, Dr.
Okay.
Dinda, you can share your slide.
Okay. So I'm gonna take like 5 minutes to explain this. I usually am better at explaining things when I have slides. So one of the 13 global health challenge by WHO is to invest on those who invest on our health. They call it as a top 10, 13 global health challenges. The problem is the underinvestment in health workers, which is us. So one of them is the regulations on residence doctor stipends and salary compensation. We had another meeting like, I think like 6 months ago. It's about the working hour regulation, but we have not reached out these many countries before this. So I hope we can, continue the topic on the working hour later on. So I'm gonna explain the vignette and a few points. The urgency is because that I told you about, WHO has that top 13 global challenge, and we are under WMA, and we were under ASEAN for the working hour. And I'm gonna show some literatures around this topic and our proposal from Indonesia on how we're gonna, make a commitment together. So the first one, our problem in Indonesia, the Ministry of Health, our health ministry, tested our residents, which are like 20,000 residents in 28 university-based hospitals, with no method explanation. They only use like PHQ 8 in last March, and found that there is depression symptoms found in 22.4 in the news. So they're trying to, after that, there is like explanation that they want to make, hospital-based programs to, direct this issue, so they are not getting targeted for bullying in a way. So there are, of course, there is South Korea here. You can explain about your condition, but we know that South Korea has trainee doctors who continue to work out overpay hours. And yeah, you can explain it that later. And then we know that some of the countries like India, they're trying really hard from times to times, 2021 to 2024, to get like 10,000 rupees increase, which is about just $100 US. And this is an increase after another $100 US increase in 2021. So it's really hard to get your income increasing ahead the years. And in New Zealand, it's also the same problem. They have the same problem. And in the USA, some universities have the courage to explain to continue fight for better wages because they feel like they are overworked, underpaid, and exploited, and they put it on billboards. We're gonna try to make one operational definitions. So stipends is a fixed sum of money an institution pays people to perform a set of tasks over a period of time, usually given during apprenticeship of internship or residency, and not considered as wages. So employers will not withhold income tax on any stipend. So it's tax-free benefit. Difference with salary. Salary is a fixed regular payment. So you have to pay tax with salary. But with wages, that's more of hourly work. So you're only paid for that specific time. This is usually earned by unskilled or semi-skilled worker with lower precision of your responsibilities. And we're going to talk about disposable income, which is a key concept in budgeting, as it refers to the income that's left after taxes and monthly expenses are paid. So your leftover money in general. Our conditions today, so that 22% point for residents who were tested of a total of 12,000 in 22 centers or 28, I forgot, like just 20s. They are found to have to show depressive symptoms using PHQ-9, which is this one, 22. 20% of a vertical hospital. Vertical hospital meaning the hospital within the government. So what we're going to talk about this, because they're trying to, trying to make this based on the bullying system in a way. There is a meta-analysis talking about this PHQ-9 to test major depressive disorder symptoms. But with 27 studies, it's found to have sensitivity, low sensitivity and better specificity. And for detecting major depressive disorder, it has to have a cutoff point of more than 10 points to have a better diagnostic performance. So by these means, someone who doesn't actually have the diagnosis can be included as having the symptoms. So by this means, it doesn't really tell if our percentage of depression caused by the systemic condition of residency is really there. It might be like really lower scored, which if we take like the 10 points, it means like we only have like 4% within the 10 to 14 or less. Or less because combined with the 20 to 27. Okay, so with that, we have to, further dig in. Why do we have the problem? Because we can't be, taking the, okay, you have symptoms and what about it? So we have to get it standard problem solving approach using 5W+1H, which is where in the practical hospitals when in March 2024, within 1 month, who the residents and how do they get the symptoms and why, what happened, and what are the pathogenesis in a way. So what do residents stress about most? The crucial question to determine solving method is not getting investigated and addressed. And this is why we're talking about the depression related to income, our main topic. What are the roots of residents' depression? So I'm getting into the literature study. Well, we're trying to find and dig in why we have that depression symptoms, if we want to call it like 22% of residents having that. So there is a determinant of specialty school competitiveness. It is told in Lefebvre, year 2019, that the residents, which is in internal medicine, they are determined by the amount of candidates getting into their internal medicine applying is based on average salary, lifestyle, perceived prestige, and personal interest. So they are getting in because of this, their interest. The first one, average salary. So the financial compensation is really related to U.S. medical school fill rate, and it shows correlation between salary and specialty selection, with substantiality of 62%. Another one, the lifestyle, which is defined in this literature as family time, buying power, burnout severity, practice free time, and degree to which work hour predictability and lifestyle can be controlled. It is said to be related to the condition of why they choose a certain specialty. So by buying power, they define it as staple needs. In Indonesia, we call it sandang pangan papan, or housing and food and leisure and accommodation. So we're getting the highlights here. Income condition will will be increasingly influential and in career choices and state decision in a specialty. And also increasing debts correlated with increasing there is also one research, I will mention it later, but it is also said that increasing debts correlated with increasing cynicism and multiple depressive symptoms in state residency. Also in, because studies are usually from USA, so yeah, allow me to explain first. The sources of stress, other than long working hour, because we already know that's one of the problem, the workload. The first one is said to be in these research, in these studies, they investigate that the personal debts from medical school and unstable financial conditions affects the stress. And the other ones is decreased confidence of jobs availability upon completion of residency. So they are scared if they can't function, and threats of residency closing. So the legal needs. These are the four that really stress them out if the residency is closing. Because in the States, sometimes programs really can close if they cannot keep up with the standards. The research also says 1 in 5 surgical trainees do not complete training. So 1 in 5 is really a big number for students not finishing their school because of financial matters associated with attrition or leaving school, with samples 1,000 and hundreds. And 50% of them reporting loans accessing more than $200,000 US, with 75% worrying about finances. Another thing is that according to Medscape survey of residents, lifestyle happiness and salary debt report, debt is consistently on top of challenges faced during residency. So really it's about money. I think like 60% talks about money more than it is talking about the hours spent. So why do, they're trying to suppress the income? There is this study in 2021. They found that the price of replacing 30 surgery residents, which each work 80 hours per week with personal assistant in one institution costs $60,000 US per resident, which is about 1.8 million US annually, which is a lot. And then replacing even a subset of resident in a large center with personal assistant or nurse practitioner proved costly in simplified model. This is what they are saying. So they're just trying to say that if you trying to replace the current residency programs, it will cost more than you are trying to keep the the residency workforce with that income. So this is highlighting a financial rationale to justify centers not only to first continue GME funding, which is the main source of the funding for salary of residents in the States, but also for healthcare systems and public to acknowledge residents' contributions to provided care. To, we really contribute to the systems of healthcare in a nation because our cheap, workforce. And third, to ensure educate employee benefits and to fund broader educational programs that further enhance GME experience. It's really just about to prove that we are that important. So residents are the pipeline for future physician workforce, constitute a significant component of current labor force in academic medical centers. Another studies found that their moonlighting activities from the studies, 35% have these jobs, and which goes from 20 hours to 40 hours. So almost like 50% have these jobs. And then moonlighting related progressively with increasing educational debt and credit card debt. So if you have more credit card debts and educational debts, you are more likely to have moonlighting activities. If you guys don't know, moonlighting means replacing someone's shift with yours. So you are coming to somebody else's shift. 55% moonlighting residents have at least $50,000 education debts versus 30% non-moonlighters, and 35% moonlighter have $3,000 credit card debts versus the 20% moonlighters. Sorry, someone, ada yang bocor, please. Okay, so moonlighters versus non-moonlighters did not differ significantly in the end of disposable income. So after you pay the rent and everything, your last income will be around $200 to $300, which is in the States, it could not pay like your 2 weeks of just food, minimum food, like just to like really minimum like I mean like 1,000 kilocalories, which is not a lot. So this is also equals 1 per 6 monthly rent. So you are left with that money. So also it's also important to highlight more than 43% of this residents with almost 2,000 residents only have less than $100 or to sometimes to the extent to have negative disposable income at the end of the month for food, rent, after they pay for food, rent, utilities, and debts. So you don't have any money left every month. It's also important to highlight this. 52% reporting insufficient funds to purchase work items like books and equipments. 30% of PGY 2 to 5, year 2 to 5 couldn't afford certifying board exam, like the actual exam they have to face. And most disturbingly, 20% could not afford safe and sufficient housing. We'll come back to that later. Oh no, actually, I have the next slide for that. With housing, there are research about it. First of all, financial strain of housing costs impact job performance and overall residents' wellness. So your performance and wellness is affected by the housing costs. So you are really stressed about it. Some populations are more vulnerable because some of us, let's face it, are not as fortunate as the others. So stipends given to the first year usually is 60,000, which is around $4,000 that left you for $100 to $200 per at the end of the month. But the income necessary for 1 bedroom in fair market rent and 2 bedroom in fair market rent and mortgage payments can only be paid 90%, 23%, and 32% respectively. Meaning like you can't really pay for this. Like it takes all your money. And 10 major cities, they call it major because of having more than 4 programs in that area. So 10 major cities identified, they have income of 60, really just the same amount, like 63 to plus 4 USD, 4K USD, with the, not much difference percentage of how much they can pay for 1 bedroom and 2 bedrooms and paying mortgage. So 1 bedroom is unaffordable in 4 cities, and 2 bedroom is not unaffordable in 5 cities, and mortgage payments is unaffordable in 8 cities. So what they conclude, housing costs are outpacing stipend growth. And here in the States, stipend growth from 2011, here is dated 2011 to 2024, growth is only 0.6%. That impact your ability to have secure and affordable housing. Hospital administrators view resident labor as an asset, so that's why they are still participating in GME funding, which is the funding for your income. But it doesn't really increase. So the consumer price index is increasing. The amount of payment you have to pay for example, for food is increasing to buy rice, but your income isn't really increasing, with significantly impact on the financial well-being, who carry median debt over $200,000 US. Okay, so yeah, you can't really buy a house with your income unless you starve yourself. And residency performance increases with stipends. It's explained in this journal, where scholarly activity, if given $1,000 US, they increase the publishing from 2 to 8, and the first primary authorship from 1 to becoming 6, with p-value less than 0.001. If limited, you can only do like 4, and primary resident authorship only 2.0. So cash is king when it comes to motivating residents to complete and publish research. So it also affects your performance. So I'm trying to get into our other countries' income. Annually, USA have around 60,000 US dollars in average, which is, if you average that per day, you only get like 20 US dollars per day. Sorry, this is hari in Indonesia, which is day. So 20 US dollars per day. In the States, if you want to eat properly, proper meal, if you cook by yourself, it costs you around 15 US dollars. I mean, like 50 for monthly, buying food and everything, and then cook it for yourself. But if you go out, at least you need like 20 US dollars. So it's just for 1 meal. Okay, sorry. Okay, so this is for how much hour you have worked. I can totally send this. So this is just a table of how we compare how welfare of our residents are in every country. And how is the state health budget? I can't find any other countries, and as per usual, their language, the state's language is the regular one, so we can only find this one. So they have like 15 billion US dollars annually to fund the stipends for residency. How do they pay it? This is the algorithm, how they pay it. So the tax, the payroll tax, and then some insurance get into Medicare. Medicare is their national insurance, which gets into the DGME, which is the one that funds our income, gets into teaching hospital and training sites, and then faculty get the revenues and put it into teaching physicians and pay the salary of the residents. That's how they get their income. So taxes and insurance give the Medicare the funding. yeah, we already talked about this. So the debt of $200,000 with your minimum of 8-year post-secondary education. Of course, we are all doctors. We've gone through like years of education, minimum of 8 years. It is perceived as inadequate by these research where residents says it is inadequate. And this is the lifestyle. $20 equals 1 to 2 meals per day, and rent for a room with adequate water, electricity, and safety and safe environment costs like the room itself costs around 1,000 to 1,500 per monthly. So in comparison, median salary of our age, 25 to 34 years old with master or high degree, found to be 70,000, which is $20,000 more than us. It saves you, the over the end month money to pay anything else. And new graduated lawyer is paid $115,000 or about $2,500 weekly for a firm with 50 to 100 lawyers. So fresh lawyer gets more income. And yeah, if you work more than I told you about the 60 hours. So if you work more than that, it means you have like less wage per hour, which is just $9. That's really low. Before taxes, so they have to pay 30 to 40% taxes here. So you have no money at all. Yeah. So this is just a meme. So you are refreshed. I wonder how much I will make as a resident. Salary of a clown, $50,000, which is around us. And when you like Dr. Dokyun or Dr. Fahim say, girls, when I say I am a doctor, they found out that I have 200,000 debts, 80-hour work weeks, and complete lack of social life. And what my family thinks I can buy in residency. Yeah, my family really thinks that I can buy stuff with our money, but really what we can buy is just, food, one meal. Okay. If this is not delivered, residents have to compensate, which is for moonlighting activities that we have talked about. Even so badly, we have talked about this. So yeah, salary. Also, there are research outside our industry. It's just say that salary or wealth correlates with depression, where I'm sorry, I forgot to put the study. There's so many studies to explain. So in Indonesia, we have a condition. I'm gonna explain that later. The case for needed, there is a research that says from 6,000 residents, they need financial literacy because they feel like they have below average understanding of finance. And 90% agreed personal finance should be taught during residency training. Okay, so I think you can read about this. Through and through Indonesian condition, this is our current constitution, which is published in 2013, that every resident actually has the right to have incentive and have working hour regulated, which is actually we have after the meeting that we have with Brunei and Singapore, we actually have pushed a letter from the minister of this one that regulates our working hour, but I don't know if that can be like a constitution. Okay. All right. So to combat that 60%, I mean, like we can tell this is the 60% of say resident depression symptoms. The 3 measures need to be taken seriously. We voice out that first, state budget should include health budget, of course, by a minimum of 5%, because Indonesia doesn't have that anymore. The minister removed that, which incorporates formulated funding for resident stipends And the formulation should surpass first minimum income in the region for the same type of energy and hours spent and skill utilized. Secondly, to cover end of month living costs to measured by 20% minimum disposable income. So with that 20% minimum disposable income, you can continue living between the months. And thirdly, basic financial education should be incorporated. Our minister have this slogan, money follow program, but it really fails to pay our compensation. So case study in that sense, in Indonesia, there is a research where a nurse typically spend 2,000 kilocalories burned in 24-hour shift with 80-hour. So if we combine everything that we formulate, living costs and everything, we get like $1,000 less actually, but yeah, around $1,000 for you to get going in Indonesia. Okay, so that's all. In our country, we have this, study, give the worker his wages before his sweat dries. Our slogan is better salary, better life in residency. Thank you everyone for listening.
Okay, thank you, Dr. Dino, for the great presentation. So, ladies and gentlemen, now we are going to begin our discussion. So, allow me to screen our panelists from each country. And maybe first, I will go to Dr. Ko or Dr. Eugene Song, who is present South Korea, to elaborate nowadays Korea strike and protests still continue or not, or how the condition there nowadays. So, Dr. Ko, time is yours.
Yes, I'll present on behalf of JDN Korea. Everyone can see the slide, right?
Yes.
Yeah,
Yes, right?
sure.
Okay. Sure. Thank you for having me and to this great conversation and our discussion following our JDN meeting, RL sessions. Thank you for JDN Indonesia for having me here and other JDN members to be here and spending your valuable time. I am Donghyun Ko from Korea, currently first year residency in Han University, Sacred Heart University in urology. I'll be discussing about medical residence working hours and conditions in Korea. I'll start from the structure of Korean residency, and I'll discuss about our roles and our expectation, what we are expected to do, and what we get from that, and our current issue, which everyone all knows. So to begin with, we just start with how our residency program are done. Unlike other countries, we have 1 year of internship. So we do this by being this year, we do a primarily medical performances like ABGA or doing EKG. Those are done by these 1 year interns who are doctors. And then we go to a 4 year residency mostly, except for certain majors such as internal medicine, general surgery, or family medicine, and tuberculosis. These majors we do 3 years. So total 4 to 5 years we do the residency in Korea. And in Korea we call them as 전공의. Like we say them in the same term. And they're all represented by Korean Intern and Resident Association, so-called KIRA. We're under the law of Act of Improvement of Residency Training Environment and Status. And then, except us who are trainee doctors, there is our professors and clinical fellows who are specialists, and we are all working under university hospitals and training hospitals. And those are work, as you see in the right side, they're working at the tertiary hospitals, which they accept the most advanced patients. And then we have second hospital or specialized hospitals, which are run mostly by specialists. And then there's primary hospitals and such as public health departments or some kind of other private clinics, such as beauty clinics. These are run by GPs who do not done the trainings or the specialist. And those whole system is run by medical law from Korea, and they're funded by national health insurance, which is mandatory to all citizens. And
Okay, tara.
so can you is the slide still on the first page?
Yes.
Sorry, so what's going on?
Also, welcome.
Can you see the slide right now?
Yes.
Yeah.
So you can see the fourth slide, right? Maybe I'll do it this way. So, yeah, you can see that. So let me start. Let me just show you again the last slide. So, you can see our junior doctors are running 4 to 5 years of residency and internship under the name of Changgongyi, and they're represented by Korean intern resident associations, and we are working in the university or training hospitals, which are the tertiary hospitals, and we also have secondary and primary hospitals. Those are all run by medical law, and they also get paid by national health insurance, which is mandatorily accepted as if you're a citizen of Korea. It's just run by our taxes. And there is some private health insurance which pays for non-insurance treatments, which are not some according to our health insurance department, which they feel which is not vital. They send it to this non-insurance treatment, and they are paid by private health insurances. In the legal aspect, we are paid. We are under the law of active improvement of residence training environment status, and the active improvement of training conditions of and status of medical residents. But although they look pretty similar, they are two different laws under the medical law. So starting from the active improvement residence training environment status, uh, the definition of training is done by performing a medical service under the supervision of specialists. So the admission to the program and the selection is done mostly from the government, as you can see. They're mostly done by scores. The number of interns and residents are assigned from the Ministry of Health and Welfare. And the Ministry of Health, they also provide the annual goals for training programs. So you can see that most of the systems are run by governments, and they're primarily vulnerable to the political issues. Another law which are under, they say their working conditions are they're legalized. So they say maximum 80 hours per week and 80 hours extension in educational purpose. So 80 hours per week is the maximum. They allow us to study until 40 hours per emergency. And they should minimally give us 10 hours of rest after continuous training. According to Article 9, they are also assigned the working conditions. They are assigned by Ministry of Health and Welfare. And then they do like a performing they do perform the training environment assessments, which they kind of hear what we feel about our system. And our roles and expectations are also written in our law for some reason. They self say that for interns, they should be able to treat and perform medical performance independently, based on the medical education from the university. So they are giving more emphasis on their educational indication from the university. For residency, there is so they each board gives a standards, and the restrictions are mostly about the minimum numbers of patients, surgeries, treatments, and examination conferences. So, for example, I brought some standards from certain major. For example, 600 inpatients and at least 50 ICU patients for first 2 years, and 20 outpatients and 100 consults in third year. In case if you are doing a residency in internal medicine. So, and to calculate this, we mostly for a doctor in a month, they should take care of 25 patients. Uh, and then that's like in normally we do like 10 to 20 patients per doctor. And then, well, according to the personal interview from our Korean medical press, they say like in US, they feel more than 10 patients per doctor is kind of very is putting the patients in danger. So they feel our number of patients per doctor is too much. And you can see for example, for the case of the general surgery, we also have to do 300 inpatients and 400 outpatients for 3 years. And they also have each minimum performed and participated surgeries for each kind of surgeries. So, uh, however, in reality, according to our 2022 residency survey done by Kira, our Korean Internet Residency Association, you can see that already, like still 24% of our doctors are overlooking their patients. I mean, they taking care of more patients than they should be. You can see that they're taking more than 20 patients. So what do we get from all this HEART program is that uh, is not really in a good mood. So you can see in the same survey, you can see 42%, almost 43% of doctors feeling their work during the training is not worth it. They also feel almost half of them are feeling that they're not under sufficient supervision of specialists when they're doing their performances. Do they work more than average of 80 hours per month? Yes, or more than half of them say yes. Uh, how many continuous days do you have worked? Like 16% already work for like continuous 3 to 4 days. They say at least 36 hours per day of continuous work. So it's still over the law. Do you get rest? Well, 33.9, so almost 34% says they cannot. Uh, so wait, can I continue? Someone's in the conversation said 2 minutes more.
Yes,
Uh,
please.
Yeah, 2 minutes more, Doc.
oh, okay,
You
okay.
have 2 minutes more.
Okay, thank you. And then so how much do you sleep during the shift? 4 hours per day. And for the payments, yes, we compare like we do get paid for about $2,892 US dollars per month, calculated as 9.3 US dollars per hours and 34,707 US dollars per year. And I do feel it might not be appropriate to compare directly to other countries' salaries, considering the size of the economy, as our Dr. Dihenda haven't spoke about the U.S. But I do believe that this can still show how our salaries are still underpaid. And then, so I brought the two examples of because we feel Korean medical systems are a combination of a European and American version. And so we brought one from the US and one from the Europe. So according to in Britain, which they're still doing their strikes too, they have told that they're paid for 14 pounds per hours before the strike. So it's their 17.8 US dollars per hours and 47,600 pounds per year, which is like 59,418 US dollars. So we compared to that, we're pretty underpaid on and as the our Dr. Dehanda suggested in the previous lecture, or like her saying, like she said that she gave a more specific numbers, and still you can see that although they're not sufficient, still we're more paid less than that. And now we are dealing with the current issues. We according and this starts from our policy proposed from the ministry and also from our president Yoon Suk-yeol on February 2024. So they have suggested medical policy called medical revolution. So they pointed out four main points directions. I'll tell you by each direction, and in the red I will tell you how we feel. So they said they will put more sufficient medical force. So they say they'll increase the number of medical students, which are around 3,000 to 500,000 from next year. And then they'll mandatorily make the 2 years of internship, and then the first year to make the interns to work in essential health departments, which is suggested as internal medicine, general surgery, OBGY, and pediatrics. And they also do the policy of maximum continuous working hours, 26 hours, which will be mandatorily done from 40 hours to 36. And they say they'll make specialist centered hospitals. They also manage the license. And then about this direction, we feel that about the number of medical students, we feel by whom, like, because there's no enough professors and there's no enough lecture rooms. There's no enough room for the medical education in hospitals too, because we have to see how the patients have been treated. Do we need that much of doctors also as a hot potato here? We are always talking about how much doctor we need because as the medical technology improves, we feel that a doctor can see more patients and therefore number of patients increasing number of patients. That also means our health insurance will also run down in the short budget. It is already in short budget, and we feel it will make the speed faster. For a 2 year internship, uh, the definition of essential health is also very vague. Like, for example, as a future neurologist, we feel we are also very essential. So there is the definition of essential health itself is very vague, and we have to understand why we have less number of residency there. because they're being underpaid because they're working so hard. You all know as a considering the quality of a medicine, we cannot just leave the patients when our working hours done. We have to take care of them, and that does not go along with this whole policy. And we do feel that these such at least suggested for departments, they require a lot of working. And also, we also feel is a 1 year, one more year of internship is really valid. We feel that's not enough. That's a too much burden for the medical students in some point. Also, the second direction given by the department is that they will be increasing the capacity of local medical system. So they'll support the local national universities. They'll build stronger network between the hospitals around the regional areas. And then they'll give political support to local essential doctor system, which they'll be more giving more opportunity to residency in regional hospitals. They'll also give financial and residential, like a place to live support to regional students in order to promote them to stay in local areas. However, uh, we first feel that just sending more residents, students to the local system would not make the hospital more functional because we are trainees, we are not specialists. So we feel that's not effective. And then we also want to say that for those financial and regional support, we have to understand why young doctors do not want to stay in those regional areas. That's because there's less patients. We know that we also have less infrastructures. We cannot perform a good amount of a medicine there, and that's the reason why we're actually leaving. But I think we have a misunderstanding. Like us and the government have a different understanding about the safety net they also say the third direction of safety net of medical accidents, which they'll be supporting us legally. And actually, and they said all doctors and hospitals should sign into insurance for legal responsibilities, and they'll support for safer ER. However, some of our residencies suggested that kind of legal support from the government will be enough because we've been sued for a lot, like US. However, we feel there is less legal support from us. And the last direction given by the government was that there will be better reward system. There will be financially supporting to essential departments, such as like in the previous direction. They'll give more fees to those dangerous medical treatments. They will make flexible payment from potential health insurance to hospitals in certain cases. They also suggested no mixed insurances and non-insurance payment. So as told you, some treatments are paid from the national health insurance. Some they are not essential or not. But however, they will say no mixture of them will be allowed. They will also establish private insurance system for that. And however, we feel that for the financial support to essential departments, we still feel that this would not be possible without avoiding the increase of medical insurance tax from all citizens. We also feel that the mixed treatment of insurance and non-insurance treatment would not be sustainable because in current system, hospitals were not able to maintain themselves under those system. And so from that, I briefly organized our current timeline. I must say that this is done in the very private view, since I'm not really like a member of the Korean Intern and Residency Association. So after the suggestion of the policy in February, on 15th, there was a student who decided to leave of absence. Our intern residents, mostly they have done resignations from February in early February, including me. And then government have asserted they are considering the penalty to doctors who are doing strikes under the medical law article 59 that they have administrative order to force to work under a national catastrophe. However, we do feel this is not uh, first of all, we do not feel this is a so it's like a danger here. We also feel that we do not have our ways to say our voices. From that, demonstration from the Korean Medical Association was done in March. And then, yeah, as you can see, more rights to perform to nurses are allowed. However, this is also very controversial. Voluntary resignation of other staffs and doctors are being said in Asan Hospital, which is one of the biggest hospitals in Korea. And now professors and specialists are voluntarily resigning from now. This is the end of my presentation, and thank you for hearing.
Thank you.
Thank you, Dr. Go. It's a really great presentation. So yeah, even in developing country, we still face issue that, according to working hours and also mental health. Yeah. So maybe after this, I will go to Japan. Dr. Oka. Dr. Maki Okamoto, cardiologist. Same as me, I'm cardiologist too, final year resident. So I can feel the experience how we need to face cardiac arrest every hour. So I will go to Dr. Maki. Please present how the current issue in Japan according to the topic. Thank you.
Hello. Can you see my slide?
Yeah, of course. Get up.
Yeah.
Time is yours.
So thank you for introduction. I'm Maki Okamoto. I'm an international affairs officer from JDN Japan, and I'm a cardiologist. Nice to hear that there are cardiologists here. And this is the brief summary of our country. Like, our population is 124 million, very high population, and also aging rate of it's approaching to 30%, and also known as a very long life expectancy country. Like, men is 181 years old and women is up to 87 years old average. But still many people dies from cancer and cardiovascular diseases. And also our country is known as achievement of universal health coverage since 1961. An overview of a junior doctor's training. Our medical school is 6 years, and after graduation, we do 2 years of internship, which means rotating each department, including surgery, internal medicine, OBGY, pediatry, psychiatry, everything. And from 3rd to 5th years after graduation, we do specializing training. And overall, until the specializing license, we need 5 to 6 years, depends on the specialty after internship, which means from 3rd year, we need 5 to 6 years up until the specialization. And challenges in our work environment, undergraduate or junior doctors. I think the training quality is different from each hospital, because we apply to each hospital, and each hospital has different training program. Generally speaking, I think we have good supervision system, but which on the other hand takes more time to be an independent doctor. And also junior doctors face long working hours as the other country have. And the average working hours is 60 to 65 hours per week, including 13 hours of night shift. And average income for the junior doctor, I mean first and second year doctor, is 2,000 to 3,000 US dollar per month. But I think it's also, as everyone says, it depends on the economic status. I would say our renting is approximately 1/3 of our income. And burnout is occurred in 40% of the young doctors, and main reasons are long working hours and too much amount of duties and routine work. And 50% of the younger doctors answered that they have experienced bullying or power harassment at least one time. And challenge is in our working environment during the specializing training as junior doctor, which means third to fifth year of after graduation. We also have good training quality or support by senior staff, and also area exposure to skill training or operation under good supervision compared to European countries or US. And I think compared to the other Asian country, we have relatively good payment of 3,000 to 4,000 US dollars per month. And if you become older and also the income increases, but you see the gender gap between the payment. And also women is with child have less achieving rate in specializing. Compared to 61%, in the men are 78%. And also our working hours depends on the specialty different, but normally average working hour is 60 hours per week, 60 to 70 hours per week. And there is a recommendation to avoid over 24-hour shift. However, reality is another day shift, night shift, and another day shift before you finish your work, which means 24 hours to 33 hours, 33 hours continuous work is normally and also specialties such as cardiology or gastroenterology, internist, or cardiac surgeon, IVR, OBGY has worse working condition due to the emergency on call, and most high risk of burnout after achieving specializing license, and it's rated as 20%. And our working condition of Japanese doctors, actually our reformation in our law of working condition is changing from 2024 April. So we just changed. And the government set the maximum limit of overworking hours as 960 hours per year, which means 80 hours per month for normal doctors. But for the junior doctors or the doctors working in suburb area, is up to 1,860 hours per year, which means 155 hours per month. And sorry, it's written in Japanese, but the current working hours is excess 80 hours is like amount of 40% of the doctor work more than 80 hours per week now. And also the government tried to regulate continuous working hours up to 8 hours. And also they set the 9 hours intervals during the shifts. But the reality is, I would say the reformation succeeded in better working condition for first and second year doctors, because we had the training system, which the government support, which means the first and second year doctor is partially covered by the government. The salary is paid from each hospital, but they need to do the program the government set. So which means they can go home by 5 o'clock or 6 o'clock, and they don't need to work weekend. But from the third year, we need to compensate the junior doctors, and also if you start the newly start the specializing, which means it takes time to do everything. So from the third year doctor, we have the very long working hours, but the salary is not compensate for their working hours. As a cardiologist, I took care of like 30 to 40 patients a day for myself. And also I had 300 outpatient to take care of during the year. And also I've done 10 to 12 night shift per month, which means 1 in 3 days I need to sleep at the hospital, and most of the time I didn't have time due to the emergency operation or something, time for sleep due to the emergency operation. So yeah, and also how those are the oh sorry, I shows here a suggestion solution, but I would say the law change is one like key step to change our working condition, and also the mindset or our cultural background is very dedicated, because the patient wants the doctor to be at any time and take care of them patient, but it's not possible for any doctor to work 24 hours for the patient, but the patient also or patient family also need to change their mind that doctor cannot work for 24 hours. And also digitalization to share the patient information is very important, because the younger doctor need to do many documentation and it takes time. And also task sharing with the nurses are also important. And also we have very much of small clinics and small hospital who need the night shift doctors, but maybe the integration of medical care within a big medical care zone will be helpful to reduce the amount of people doing the night shift. And also we have the very high rate of depression rate of 20%, but there are no official support or mentor system for younger doctors, which we need immediately. So overall, I think the Japanese junior doctor suffering from more long working hours status than the payment. And due to the long working hours, maybe the payment is lower, minimum, lower than the minimum wage. And especially about the working hours, we had changed our law from 2024, but the reality is not changed. And the problem is the government is recognize the learning time out of our working hours. So junior doctors need to learn outside of our working hours, which is not paid. And also the doctor who work for the university hospital is more governmental, not the private hospital. Is 1/5 of the doctor is unpaid, and they either pay for their PhD program or either pay for the education, but as reality they work for the patient without paying. So it's the like unwritten of reality in Japan. And also mentor support are needed to avoid burnout or health problems. And some of the doctors had karoshi, which means overworking to death. And overall, we think our education training system are well organized and have good quality, but the problem is that our working hours is not really regulated from the government. So we think we need to change that. Okay. So thank you for listening.
Thank you.
Okay, thank you, Dr. Okamoto, for the presentation. So yeah, I can feel you how cardiologists as me in this beautiful island in Flores. I serve a 3 district and only me, the only cardiologist here. So I need to be healthy, but sometimes burn out too. Okay, and maybe we will go to the south. We have Dr. Adel Riaz from Pakistan. So if I'm not mistaken, in Pakistan, there is a Youth Doctor Association in each district, maybe in Punjab or Lahore or Islamabad. So is there any JDN too or not? I don't know, but maybe we will listen to Dr. Adel. How condition there and how Pakistan young doctors fight for better futures. Okay, Dr. Adel, you have 5 until 10 minutes to present. Time is yours. Please unmute. Yeah. Okay.
Yeah. Are you able to see my screen, right?
Yes.
Yeah.
Okay, perfect.
Maybe you need to slide shows so we can see better.
Okay, yeah, let me do that. Yeah, for sure. Okay, how is it now?
Yeah, much better.
Okay, yeah, perfect. Thank you so much. So, hello everyone. My name is Adil Riaz, and I am a recent graduate from Pakistan. Clinically, I worked for 1 year in public hospital in Pakistan, and now I am pursuing my career in public health, and I will start my MPH in social medical sciences at Columbia University, New York, in later this fall. And as far as JDN is concerned in Pakistan, we do not have proper JDN structure currently in Pakistan, but we do have PMA, which is Pakistan Medical Association, and it is currently led by senior doctors. And as you know, junior doctors are not taken serious in our part of the world. So there are a lot of issues going on, and I was also directed by JDN management to be in touch with them, but that issue needs to be solved another time. So I will get back to this my presentation here. So first of all, let's talk about medical training structure in Pakistan. It's uniform across the whole country. There is no differentiation between how many years or how many years of training program will take place. Like, for example, medical school all across Pakistan takes 5 years. Either it's private or the government setup. Then once a person is done with medical schools, the person is required to do mandatory clinical internship for 1 year. And clinical internship is further divided into 3 months each in different specialty. So 6 months in medical field and 6 months in the surgical field. So this is how it's divided. And after doing mandatory clinical internship, the person is granted the permanent license to practice medicine in Pakistan. And after that, if a person is interested to pursue medical career in Pakistan, they may take the route for postgraduate training that is 4 years. It's uniform all across the specialties, be it medical specialty or any kind of surgical specialty. So it's just 4 years, and it is divided into first 2 years. Then they have to take an exam in between that. It's called IMM, and then after 2 years they have to take the final exam to pass all the clinical things and the academic things that they have learned during the 4 years. And then they given the fellowship by College of Physicians and Surgeons of Pakistan, and then they become the consultant after that. As far as the junior doctors are concerned, this is the hierarchy in the Pakistani medical healthcare. First, a person who is doing mandatory clinical internship just after finishing medical school is called house officer. And a person who has done the clinical internship and not into clinical residency of post-graduation, the person is called as medical officer. They are doing non-specialty job in appointed by government. And then there is a postgraduate trainee, and then there is consultant, and then associate and assistant professor, and then the full professor. So as far as the salary of the junior doctors is concerned in Pakistan, the house officer is paid 70,000 Pakistani rupees, which amounts for $250 per month. And medical officers are 90,000 Pakistani rupees, which is roughly 322 United States dollars. And postgraduate trainees are also paid the same. It may differ into, some kind of amount, but usually it's the same amount they are being paid all across Pakistan. So when it comes to the working hours, so house officer work almost 100 hours per week, and medical officers have 40 hours per week duty, and then postgraduate trainees work almost 70 to 80 hours per week. So these working hours are usually divided between house officers and the postgraduate trainees, and they have one mandatory outdoor clinic once a time a week, and then they have this emergency, which is of 24 hours. And after doing 24-hour emergency, a doctor is mandated to do the post-round clinics in the hospital setting also. So it usually amounts to 50 to 55 hours in a single row, a duty per week. So this also, explains a lot of things in Pakistan that's happening right now. There are no regulated working hours. So it usually depends on the, seniors in the ward, or the person who is managing the ward, and how many working hours will be given to the particular doctor. So there is not much uniformity around that. And regarding, this is the last slide. So what are the potential issues that junior doctors are currently facing in Pakistan? Of course, as I talked about the long working hours, these are non-regulated hours. Seniors can push you to work for how many hours they think it's better for them, or maybe and then on top of that, if you are working extra hours in the hospital setting, you're not being paid a single penny for extra for that. And as you can see, Pakistan is currently facing for double-digit inflation, and $250 in Pakistan is nothing, especially if you're taking care of your family also, you're not a single person. And then housing itself is cheap in Pakistan. Like, for example, a junior doctor is given the cheap option for housing inside the hospital by the government, which is very, very at low cost as compared to the other private housing. But then if you have a family, it's very difficult to, take care of everything. And then there is no health coverage included in the government job also. You have to pay for yourself out of the pocket for your healthcare. And then there is a biggest issue in Pakistan, that is violence on healthcare workers. There's a lot of issues happening in Pakistan. Like, for example, 2 months back, a group of patients, because their relative died, they attacked on the doctor, and the doctor literally suffered from intracranial hemorrhage, and it was a big issue in Pakistan. And then there are no repercussions around that. Even though there were the videos circulated in the social media, the person went totally free at that night. The person was not given any kind of compensation, and the doctor suffered permanent damage to their, body. So there is this issue also, and then there is no digitization of patient records. All in all, junior doctors have to do everything on paper, and they have to take care, like the long patient records. And once like paper get missed somehow, then the junior doctors are, blamed for everything. And it's a long and tiring procedure also. So this was my short presentation from Pakistan. I hope I was able to get across my point. Any further questions are welcome. Thank you so much for having me.
Thank you, Dr. Adel. Yeah, I saw many news about the violence in Pakistan, and it's important for government to make law protection. And also in Indonesia, if we go to the rural area or to the war area, we need to sure that we have protection for our life. So yeah, maybe we will go to the ASEAN country. Dr. Shi from Malaysia, are you okay to present? Okay, Dr. Simon from JDN Malaysia, you have 5 minutes until 10 minutes to present the Malaysia condition among medical residents. Time is yours.
Sure, thank you. Thank you so much for inviting JDN Malaysia. Let me share my screen. What's Can you see my screen? Yeah, okay.
Yeah.
So I'm putting in the slide mode. Right. Okay. Hi, everyone. My name is Dr. Lok Ziman. I'm from JDN Malaysia. You can call me Z. It's easier to remember that way. I'm a surgical trainee in the Department of Surgery in Sultan Abdul Aziz Shah UPM Hospital. And I also represent the Junior Doctors Network, a part of Malaysian Medical Association. So let me walk you through how is the journey of a Malaysian doctor. So right after medical school, what happens here is it's a compulsory 2 years of housemanship training. So every house officer will undergo 4 months of each rotation in the Department of Medical Surgery, orthopedics, ONG, PEDS. And they will have an elective option. They can either choose psychiatry, emergency department, or anesthesia. Now, after the 2 years of house officer training, then they will become a medical officer. So this medical officer will enable them to pursue their postgraduate specialization or their postgraduate career pathway. And but unfortunately, or fortunately, I would say, not sure, our current issue with the Malaysian doctors, we are now has already changed from a permanent position to a contract employment. So meaning all the juniors doctors now in Malaysia is on contract basis. Now, I did not go through contract. I was still in the old system where after I complete my 2 years of house officer training, I will become a permanent staff right after that. But things have changed almost about 6 to 7 years now. The junior doctors will need to take on the contract employment right from house officer itself. And this contract will stretch up to 7 years. So after finishing 2 years of house officer, this junior doctor will become a contract medical officer. And with the contract scheme, there were many changes in terms of salary, in terms of career advancement, and other privileges transfer from one state to another when you are asked to serve another state, and many other privileges. So, but these things, these changes have been evolving, and it's still evolving. My Malaysian Medical Association is very concerned and very passionate on fighting for the rights of junior doctors, regardless contract or permanent. We believe that everyone should be treated the same. So a few changes that has gone through the contract scheme. One of them was the contract doctors are allowed to apply for postgraduate training when they're at the contract scheme. But you must have at least 3 years of service right after your house officer training, so to qualify for the master program. So a minimum of 3 years before you can apply for postgrad training. So once you get into postgrad training across the board, it takes 4 years for us to become a specialist. And in this specialization pathway, you have the master program, which is the local program offered by the local university, and you have specialization pathway by the parallel pathway. If you watch the news right now at this point of time, for the last 1.5 months or so, there were issues on the parallel pathways where certain departments, certain specialties are not being recognized or would be potentially de-recognized from their specialization because they were graduates from the parallel pathway. However, this issue has been taken up by Malaysian Medical Association, and we are fighting for the rights of these doctors. So as you can see, in every part of the journey of a Malaysian doctor, there seem to be ups and downs, there seem to be hurdles, and it's not an easy feat, but what we wish to portray to the Malaysian population, to our nation, that we need to reduce waiting time, but we are losing doctors. And for the last 4 to 5 years now, many doctors have exited the Malaysian healthcare system. Many doctors have left the current healthcare system in Malaysia, and that has caused additional burden to the doctors who have stayed in the hospital because of manpower shortage. So right after you finish your specialization in Malaysia, you must undergo 6 to 18 months of gazettement, depending on your specialty. Then thereafter, after 2 years, you may again start specialize. For example, if you're a GI surgeon, you're a general surgeon, you can take up subspecialty in GI surgeon per se, or you want to specialize in say vascular surgery and so off. But with parallel pathway, we have about a couple of disciplines that you can go directly to the program. A couple of them are urology, neurosurgery, plastic surgery, ped surgery, and a couple more. So now, last year we've conducted a short survey, and this was presented during our Doctors' Day celebration last year, and to highlight the challenges that Malaysian junior doctors face, and that has caught a couple of media attention. So I would like to share with you, since we are talking on doctor stipends and working hours, our survey had captured some data that 60% of junior doctors with less than 2 years of experience had worked overtime every day. and 20% of doctors beyond 2 years of experience, meaning the medical officer pool, and also had also worked more than 30 to 40% at least 3 times a week. So this was one pictorial. I'm sorry, it is in our national language, Bahasa. But I want to highlight to you that the system has, the Malaysian healthcare system is already burdened. And with people leaving every month, now every day probably we have doctors leaving, this will add on, you know, the burnout burden that we already is suffering. And I want to highlight to you now, this is a pictorial picture to tell you that these are the workload of doctors on call. Okay, when we do on call, this is what we do. Allow me translate English. So we in average we have about 2 times of ward round, one in the morning and one in the afternoon. And then on average, a junior doctor will need to take care minimum of 30 patients. And I'm sure the numbers have gone up now with the manpower shortage. Probably one doctor will have to take care of 2 wards, and that could amount to 50 to 60 patients easily. And when you're on call, you are expected to take referrals from entire hospital, be it from other ward. For example, if I'm a surgical doctor on call, I will have to take referrals from medical colleagues, from pediatric colleagues, you know, and also in the emergency department. And as a surgical on call, I would also expected to do any emergency surgery. And I'm sure our ONG colleagues burden if on that day, you know, there are many deliveries to be conducted, you know, based on emergency basis. And we are also expected to take care of acute patients that are stationed in ICU. We have to, you know, handle patients who need acute treatment. Probably in the ward, they suffered chest pain, and we have to come to a diagnosis. Is this patient suffering from heart attack or pulmonary embolism and whatnot? And we also expected to plan, you know, what bloods to draw from the patient, you know, to monitor their parameters, or any emergency x-rays or CT scans that need to be done, or if these patients require emergency dialysis. And of course, the junior doctors are also expected to take the bloods of the patient. They need to draw the morning bloods, means the blood that need to be reviewed the next day. And this is the job of an on-call doctor. And in the morning, we are expected to have to follow a Passover round, where we need to present the cases in the ward and also new admissions from our night call. So all of these tasks that are expected for any on-call doctor to perform in Malaysia, it is we have this on-call allowance, and it's about 200 ringgit on a weekday, and additional 20 ringgit Malaysia on a weekend. And for our specialists, on-call allowance are just 30 ringgit difference. So if I were to do a calculation on our currency, if we are to compare with USD, which is not fair, 200 ringgit on a weekday of on-call allowance is amount to only $49 for a doctor to take home. And that is equivalent to 9 ringgit, 16 cents per hour, and that comes up to less than $2 American if we were to compare. So this is the situation in Malaysia. Now, the Malaysian Medical Association has submitted a proposal even before this survey was presented last year. And, you know, we are proposing 25 ringgit increase from 9 ringgit to 25 ringgit per hour. And that would be ideal. So if we were to convert to USD, is only $5 per hour. for these doctors to take home. And if 25 is too high, we would appreciate that it is at least 20 ringgit per hour, but we would like that to be revised after 2 years. If this proposal is not being accepted, and that is very sad because the last review was more than 10 years ago. Now with that, I end my presentation.
Thank
Okay,
you.
thank you, Dr. So yeah, maybe in among ASEAN country, we face the same problems, and we always face government to build a good recommendation for us. But until now, Indonesia still no get the right for medical for doctor. Of course, medical residents too. They cannot get the appropriate rights. So thank you, Dr. Z. Maybe it's unfortunately Dr. Hakim from Brunei need to leave the discussion. So maybe we will go to the Singapore. Dr. Tay Min Lee, are you there? Maybe you need to unmute first. Dr. Tan Min Lee from Singapore, can you hear me?
Hi
Maybe
everyone.
some trouble.
Yeah,
Yeah,
I'm so
okay.
sorry because so there was some vacuuming that was going on, so I had to ask.
Okay,
So,
Doctor, you have 5 minutes until 10 minutes to elaborate condition in Singapore and related to this topic tonight.
yeah. So
And it's
I've got to
yours.
apologize. I found out about the meeting quite late, and I didn't actually prepare slides beforehand. But there was some information on the Ministry of Health's website, which I thought could serve as a bit of graphic as I share a bit of what we do in Singapore. So I'll just share that. So I'm currently a first year trainee in radiation oncology, and I graduated in 2018. So I guess similar to Malaysia, where we've got like a housemanship year, a house officership year, or in Pakistan where we have got house officership year followed by a medical officer duration as a medical officer. I went through that, so I had a year as an HO, and then a couple of years as an MO where I rotated through various specialties. So I did mainly surgical subspecialties because that was where I was interested to explore. And then I later joined a residency in radiation oncology. So there are two parallel tracks, and my experience may not reflect that of everyone's. So some of my colleagues would have started residency earlier and some later. But so essentially 5 years of MBBS, 1 year of housemanship, MO years would vary. So like myself, I had 4 years as an MO, but some colleagues would have 1, some colleagues may enter training right after house officer year, although that is becoming less and less common. And you could choose to also sign on as a resident physician, which is a non-consultant role, like similar to a staff grade physician in the UK. And if you enter training, that is that ranges between 4 to 6 years and is program dependent. So for my program, that's 5 years. For family medicine, that is shorter, it's 3 years. But typically would not. So you've still got to follow that on with 3 years of fellowship before you end up at the same grade as a hospital doctor. So varies, but generally between 4 to 6 years. All house officers and medical officers are centrally employed by the Ministry of Health. So we are paid by this holding company is called MOHH. So they fund the salaries of all house officers and medical officers. But when you sign on or when you switch on to either a resident physician or a consultant, then you would be paid by the hospital. So yeah, so similar to earlier. So residency is newish to Singapore, but so already for the last 10, 15 years, started in 2010. Essentially, they tried to formalize training to get us to follow, like the ACGME, where the GME in the US, where they track working hours and things like that. So this was instituted back in 2010, but in practice, it is actually not followed. They've got surveys where they send out and you've got to report your working hours, but in reality, nobody really, or rather, if you accurately report your hours, and then you may get questioned, why are you submitting this and stuff like that? Because if the program has people working too many hours, it may not pass and things like that. And so I would say there is in theory some form of work hour regulation, but in practice on the ground, it's not actually being followed. And there are also some training programs that are not part of residency, like radiation oncology. So we don't have something like that. Although I would say for an outpatient specialty like mine, the work hour challenges are definitely much less difficult than what some of you all have shared. Like for instance, what Dr. Okamoto shared, right? Like in cardiology. So I took some notes along the way as the rest of you were speaking, and I thought I would just share some of the small little pointers that I took down. So I think the major differences I noticed was that in Singapore, we've got no formal union to speak of, and protests are illegal in Singapore. So even though working hours is still an issue, we cannot formally protest against the government because that is illegal. We are not allowed to moonlight, so we cannot take on part-time work to supplement our income. In the past, it used to be done sort of illegally and people close one eye to it, but they've become a lot stricter, and there have been doctors who were charged in court for moonlighting. But in Singapore, the way moonlighting usually works is by working in a private general practice clinic outside of your hospital employment. So, and that usually pays much better. So, locum in that setting could be paid something like 90 Singapore dollars an hour. But if you were to be working in a hospital, your call allowance would be, so for a medical officer would be about $200+ overnight. And our starting salaries as a house officer, so that was when I started work, was about 3,600 Singapore dollars. I think there has been some readjustment over the years, so I'm not sure what the current rates are. Yeah, but the pay is standard across the various specialties. Yeah, I'm not sure what else I can share because I'm not sure what else I can share that would be helpful, but happy to answer any questions if you all have anything specific to ask.
Thank you.
Okay, thank you, Dr. Tan Min Lee. So maybe we will go for the last country, but it's not least, yeah. From JDN, Thailand, we have Dr. Prindrasar.
Yes, hello, can you guys hear me?
Yeah, okay. You have 5 minutes until 10 minutes, Doc. Time is yours.
Thank you. And this is free time.
Yes, we can see it.
All right. Okay, thank you. So this one is the last presentation, I believe, from Thailand's perspective. And just to get to know you, because I believe that our meeting here doesn't just end in this meeting room, but there is much more things that we can do that collaboration. So hi, and my name is Prasar, and I'm actually an intern in Bangkok right now. So I graduated Bachelor of Medical Science from Nottingham, and also MD from Singapore University in Bangkok. And if some of you guys know IFMSA, I also did school PRA for Asia Pacific a few years ago. And right now, I'm also advocating for this topic as well in Thai Frontline Physician Unit, which we are actually forming within the past few years. And so to talk about the medical education structure in Thailand, similarly, we have medical school for 6 years, and then we have a mandatory internship for 2 years. But that also depends on what residency you would like to go to. Some residency only take a minimum of 1 year of internship, but mostly it's 3 years. And then residency is 3 to 5 years, depending on the specialty, and then fellowship for 1 to 3 years. So the current situation in Thailand, as a lot of us already know, the WHO's recommendation of the ratio of doctors to population ratio should be 1 to 1,000. And in Thailand, from the last data, we have the ratio as 1 to 2,800. And this already like includes the physician on leave, like some of you have mentioned, like physicians who is in university or someone who is studying abroad, but actually who is the people who are actually working physician, that ratio would be 1 to 3,600. But also we have to take doctors' allocation into account. So in different areas of Thailand, this differs really much. So as I said, here in Bangkok, it's 1 per about 500, versus in rural Thailand, it could go up to 1 to 3,500. And our Ministry of Public Health uses the ratio for standards 1 to 1,200 as a standard for middle income. That's where we're hoping to achieve hopefully. And I guess one of the good news is we have increasing number of medical graduates each year, and this number is going steadily around 3,500 per year. However, the dropout rate is still concerning, with about 10 to 15% of students leaving even before the medical students have completed. And also, as we all know, mental health issues, depression and burnout is also significant, as much as in any Asian countries. So in 2017, the Thai Medical Council announced regulation that they would like to suggest regarding doctors' working hours. So they said that the working hours of doctors outside of the official regular hours should not exceed 40 hours per week. So that means that that's a total of 80 hours per week that they suggest. And also during the emergency and accident shift, that should not exceed 16 consecutive hours. But what happens in reality? This is one of the big research paper from Dr. Niti, who was also in the Thai Medical Council back then. He conducted a research and with about 1,000 response. So it found out that doctors are working more than 80 hours per week. That is 90% of the doctors that respond. And also 60% of the doctors that respond working more than 120 hours per week. And also 90% of us said that we continuously work for 24 hours compared to what was suggested before this. And also other things that he found out was that there are medical errors due to inadequate rest, and that was also responded in 90% of us, and also serious adverse events, disability, and prolonged stays that also is an outcome of not having proper working time. So that means that after the first 2 years of the medical council announcement, only 10% of doctors were able to adhere to the regulations that came out. And as of now, there is still no working time laws or regulations that is actually enforced for physicians in Thailand to this day. which I have listened to some of you guys that you guys have this working time regulations, and hopefully we will get there someday. So of course we can't talk about the working hours without talking about the money side. So the resident stipends, the doctor's stipends usually is divided to the base salary and also additional salary. So from the Civil Service Commission of all foreign Thai and also Ministry of Defense, because some of the hospitals in Thailand lies under like the Ministry of Defense for like the soldiers hospital. It says that residency is education and is not like performing in a position that should receive additional income. So we don't receive like more additional income than the base. But of course, like we comparing to the responsibility, we only have minimum cases that we have to do to pass residency years, but no maximum. So that completely depends on where you go to residency inside of Bangkok or outside of Bangkok. And also, like I said, there's public hospital and there's also like military hospitals. So civilian doctors, so most of us usually our salary range between 500 to 540 US dollars. And for military doctors, that range by their ranking. And the more that they work, the longer they stay, they get more. So that's around 570 to 590 per month. And also, so civilian medical doctors, just explaining why we have this ratio is from like the graduate employee in the medical field, that's about the same rate. That's where they got this number. And also we have shifts as well, like night shifts and after official hour shifts. So that is around 1100 to 1500 baht per month. So that is an extra of 300 to 400 US dollars. And just to elaborate on the on-call duties here, that also completely depends on the hospital. Some pays a fixed rate monthly, which means that they give this amount monthly and they can basically allocate you how many shifts they want. Maybe you work 15 days, 15 whole days per month, or you can work 30 days per month. And that completely depends and no one can do anything about it. And some pay depending on the number of the duties per month, and yeah, so there's some difference. So in summary, the income, total income for one Thai resident, that would be that's a mistake there. So about the maximum, that would be 1,000 US dollars per month. And so it was really interesting for me to see the numbers in comparison to like all the other Asian countries. And I think that we can definitely do better since the introduction, we've already established that better stipends means better performance of doctors and residents. So definitely we can do something here. And I'd like to ask you yourself in the audience to ask yourself, like, what should we do in this moment? I'm just an incoming surgery resident, so I'm actually just an intern now, but hopefully I'm using my voice, and by joining this, I think this is my first JDN meeting as well. So I'm very honored to be here and very happy to be collaborating with everyone here. Hopefully we can use our voice as much as we can to voice this out to the people and the stakeholders who can actually make a difference. So yeah, let's advocate and keep pushing forward this agenda because it's not just residents. Like if you're an intern, this is your future. If you're a resident, like many of you here, you're living this truth. And if you're a senior or if you're even in the management sector, this could be your future doctor. So I believe it is everyone here who can actually make a difference. So thank you. That's almost the end of my presentation. And before I go, I'd like to offer some collaborating pathways that you could probably reach to me. So JDN Thailand, you can message us. And also I work for TFPU, so Thai Foreign Physician Union that we are trying to form. So TFPU also advocates for better physician working conditions, including proper salary, working hours, and healthcare system as a whole. And furthermore, if you want to talk to me or talk about the Thai healthcare system, personally, you can also add me on Facebook, and my name is just right here. So thank you very much. And yeah, that's the end. So I'll stop.
Thank you, Dr. Asar.
Thank you, Dr. Rasar. So yeah, we have already listened to all country participants. So according to a presentation, I think there are three important things. The first is compensation salary. The second is working hour, and the third is security or law protection. So maybe how can we team up together to push this to an agreement to make it this discussion as a advocation echo in the future. So maybe anyone want to share
I actually have an
opinion
idea.
about that?
I have an idea. Like most of the campaigns now use the social media in combination. Like if you guys, like Malaysia, Korea, and everyone here have your social media of your JDN, we can combine with our JDN and toss it together. So we have like really diverse people seeing the same thing, issues about this. I think that's one of the easiest way. Thank you.
Yeah, as maybe I resume the presentation from every country that the regulation of medical residence stipend, working hours, and salary compensation is really important and vital for our well-being, and it's in this healthcare professional and the quality of patient care. So we need to maybe any idea for like a movement in social media, or maybe in each country to make it a noise, and maybe in the future the government from each country will see that it's needed to what we call it, we need to fulfill something like that.
About that last one, can we just have the official JDN of every country here put it on the chat section so we can save it and then contact you guys about it? Maybe other countries have other additional suggestion about how we can push this issue together.
I think Dr. Dinda, Dr. Indonesia, I think will make a draft or something like that. That after that we will send to all the participants to tonight, and then maybe in 1 or 2 weeks we will send it, and then we will have some comments from all of you, and then we will post it into our GDN's Instagram or Facebook or something like that. I think that's a good idea, in my opinion.
Agreed.
Okay, I saw Dr. Baki raise hand. Okay, go for Dr. Baki. You can unmute.
One suggestion. Today we had so many different types of presentation to know about each countries, but maybe in order to compare very briefly, maybe it's gonna be easier to ask same question and answer same question, like how much money do you earn as average, and how much will it cost for one room apartment or something like that, to compare each country difference. or working hours and salary things. So maybe it doesn't have to be very long questionnaire, but maybe we can compare it with the same things and then make a graph and then show as a difference. And maybe we can also compare it with the European or US, how much worse situation we have as Asian countries. And one additional suggestion is to take one screenshot of us gathering for the first time with
Dr.
so many
Ratu.
people
Yeah.
to show off to
Dr.
our like
Ratu.
social media that we are corroborating each other to help
Yeah.
make our
I actually
situation
remember
better.
that. I did remind Dr. Ratu, please, because Dr. Hakim is not here anymore. Right?
Yeah, I think Dr. Maki idea is really good, yeah, because visual is more better and more easier to reader to understand. And I saw too Dr. Eugene Song raise hand. Please, doctor.
Oh, yes, I did indeed raise my hand. My name is Eugene from JDN Korea. And because of the problems that we have in our country right now, our Instagrams and our social media options are not actually available at this point. So I was wondering if for countries like us, I mean, this is a very meaningful gathering that we have here, and I really do want to continue our collaboration as an Asian community. And I was here with Dr. Wuna from Myanmar, and he suggested that we make an Asian Pacific working group for JDNs from these countries. And I thought that would be a nice platform that we could also utilize. And as to add on to Dr. Maki's idea about the questionnaire, I think it is a very nice idea that we do a proper questionnaire to make this database that allows us to compare and contrast these amazing information that we have gathered today. And we might use these information to maybe write an article for the World Medical Journal or the JDN newsletter, I hope, in the near future. Thank you.
Thank you, Dr. Eugene. It's really brilliant idea, yeah. So maybe in the future, we any a working group for us from Southeast Asia and South Asia, East Asia to elaborate more, not only the current issue now, but of course for knowledge and maybe technology transfer in the future, yeah. Okay, maybe we have limited time due to different time zone. So maybe I would like to ask every participant to open the camera so we can take a picture first before our face looks sleepy. Okay. Okay, Dr. Nikadek from Bali, I think. Dr. Prindrasar still close the camera.
Dr. Tommy.
Okay. Dr. Tommy. Dr. Gatut. Okay. Dr. Halim, Dr. Ahmadal, and Dr. Nikadik from Bali. Dr. Anissa, Dr. Abdul Aziz, please open the camera just for 5 seconds. Okay. I will take a picture, yeah. 1, 2, 3. Okay. Once more. Okay. Another pose, maybe. Love. Okay. Okay. Okay, maybe we will continue with idea from Dr. Maki and Dr. Eugene. So please keep in touch, everyone here. And as a moderator, maybe I will give a conclusion from our meeting tonight. That's we need to push any government worldwide to prioritize the welfare of medical residents and implement policy that promote a balanced and sustainable work environment. And together, we can create a culture of safety, health, and respectful for all healthcare workers, including medical residents across the world. So maybe this is the last part from me. So thank you for your attention. And for next season, I will give back to the Dr. Putri or Dr. Ratu. Please, Dr. Ratu, time is yours.
Just one short sentence, Dr.
Oh, maybe, yeah. Okay.
I would like to
Go ahead,
say
Dr.
thanks to all of on behalf of JDN Indonesian Medical Association. I would like to say thanks to all of you from Malaysia, from Singapore, from Thailand, from Korea, from Pakistan, and then from what else? Brunei and Japan, and also from Indonesia. I think it is a great honor for us to become a host, the first host of Southeast Asia, South Asia, and East Asia collaboration for this meeting. I think there is an opportunity to meet in Malaysia, I think in next month, but I think it is only for Southeast Asia, I think. But later in the future, maybe we can have an offline meeting, but I think we need to have some more online meeting after this. Maybe Dr. Maizan and team, Dr. Dinda, and also from Indonesia, we have some draft and question or something like that and post it on WhatsApp. I think we can have a WhatsApp group, and that's all from me. Thank you, everyone.
Thank you.
Thank you, Dr. Tommy.
Thank you, Dr. Tommy. So maybe I after the my connection is unstable now. Okay, I will give to Dr. Putri or Dr. Ratu.
Okay, thank you,
Dr.
Dr.
Ratu
Manu.
still there? Yeah, okay.
Thank you. Once again, thank you everyone for attending the meeting. Thank you, Dr. Song Eugene, Dr. Dong Yun Ko, Dr. Maki, Dr. Adil, Dr. Taimin Lee, Dr. C, Dr. Rasar, and Dr. Dinda. And also thank you, Dr. Maizan, for leading the discussion tonight. We have such a delightful discussion, and hopefully tonight's discussion can help us to work towards better quality of life for medical residents. Okay, we from JDN Indonesia are definitely looking forward for our future collaboration. And once again, thank you for everyone joining the meeting. Okay, meeting's adjourned. Thank you.
Okay.
Good night, everyone.
Good night, everyone.
Good night. Thank you. Bye-bye.
Yeah, keep in touch in group ya.